Okay. Mm, a previously healthy 32-year-old woman comes to the physician because of 4-month history of increasing pain of both breasts. The pain is worse immediately prior. The pain is worse immediately prior to the onset of menstrual period. She states that she does not perform monthly breast self-examination because of the pain and the numerous lumps. A paternal aunt has a history of breast cancer. The patient takes no medication, means occur at regular 30-day interval. Her last menstrual period was 16 days. The examination of the breast shows bilateral tenderness and nodularity. No mass can be palpated. There is no galactory or nipple discharge or axillary adenopathy. Which of the following is the most appropriate next step? Mm,
Hmm. Mm, no. Ready?
yes.
So it is a second exam on day 9 of her next menstrual period. That was a good guess. Fibrocystic changes of the breast occur most commonly in premenopausal women. Patients may present with various sites of breast pain and lumps, which may be bilateral. The condition is characterized by presence of cysts, stromal fibroids, and apocrine metaplasia on histology, and is believed to occur in response to hormonal fluctuations during the menstrual cycle. The examination after menses, day 9 of the next menstrual period, may be helpful for diagnosis because the size of fibrocystic changes should subside after menses, distinguishing it from other causes. On exam, the cyst may appear blue. Fibrocystic change is a benign disease and does not increase the risk of cancer except for certain subtypes. However, it can result in recurrent breast pain. If there is associated discomfort, aspiration can be done, which may relieve the symptom. Cyst aspiration can yield fluid that is clear, milky, yellow, green, or brown, which are all benign. Supportive care is also appropriate using NSAID as well as a fitted bra. It is not CDNE. It's not mammography. Oh, she's 32, yeah. Mammography is most used as a screening modality to detect early stage of breast cancer, although it may also be used to aid in diagnosis of a palpable breast mass. However, ultrasound is more commonly used to aid in diagnosis for patients under the age of 30. I thought it was 30 anyway, as the breast tissue is often too dense to be, yeah. Ultrasound of the breast is frequently used in the evaluation of breast lesion for patients under 35. It can determine the need for fine needle aspiration, breast cyst, or further imaging. This patient has no lump, which will make ultrasound ineffective. MRI may be used for evaluation of breast lump in patients under 35, but is more commonly reserved for evaluation of patients with breast implants or those with a high risk for developing breast cancer, BRCA mutation. This patient may require additional image in the future, but she's fine now. So is it 30 or is it 35? Because we learned it was 30, less
Yes.
than 30. But in a lot of questions, I see 35 now. So I don't know if it's something that they change. You know how they keep changing the rules.
But if change occurs, then the change may come in the U world, isn't it?
Did you see the change in the UR? I don't remember.
Not really. There was the same box as previous in case of breast cyst.
Okay, okay. Now it's 30. Let's keep it at 30 then. Next.
But why not ultrasound? Because there is no lump. But in the question stem, there is lump, numerous lump.
No, a breast mass.
The patient
No,
has, sorry,
the question
yes,
stem doesn't have lumps, does it?
yes, numerous lumps. She
Where is?
takes, she does not perform monthly breast examination because of pain and numerous lumps. It
Um,
does not fit with the explanation, isn't it? They actually
mm,
said,
it it fits because the I think
is
the
it
mammogram
fibrocystic diseases related
is
to
fibro-
menstruation?
yes, fibrocystic disease is related to menstruation. I think
Okay.
when they say for mammogram and ultrasound, it has to be a mass, like the
Lump
mass.
and mass is the same.
It's okay. Maybe they didn't use the right thing with lumps here, but I think the point here was that you're supposed to know it's fibrocyst. After you read the question, you're supposed to know, oh, it's fibrocystic disease, so it's not a mass. It's just related to his her menstruation.
Okay.
Yeah.
A 3-year-old girl is brought to the physician by her father because of vaginal discharge for 2 days. She has been scratching her vulva and appears uncomfortable. There is moderate amount of bloody, foul-smelling vaginal discharge. Which of the following is the most likely diagnosis? So come on, let's try this.
Ready?
Scratching. Okay.
So it's foreign body. Vaginal foreign bodies can present in prepubertal children with genital discomfort. Vulvar genital discomfort, vulvar redness and pruritus, vaginal discharge, and vaginal bleeding. The most common foreign body is toilet paper, but other objects such as mouth toys, toy bars, and coins may be inserted due to the child's curiosity and exploratory genital play. Diagnosis with visualization of the vaginal walls, saline irrigation, and examination under anesthesia may be required. Treatment requires removal of the foreign bodies. No candidiasis classically presents with vaginal pruritus, vulvar redness, and thick white vaginal discharge. It's caused by overgrowth of candida. It will be unlikely to present in a patient this young and will not commonly cause bloody vaginal discharge. Okay, next.
A 38-year-old woman, gravida 3, para 2, 12 weeks of gestation, is admitted to the hospital because of one day history of heavy vaginal bleeding and moderate abdominal pain. She also feels jittery if she if her heart was racing. Her previous pregnancies were uncomplicated and ended in vaginal deliveries at term. Her last menstrual period was 3 months ago. Mens previously occurred at regular 3 to 4 months interval. The patient has no history of serious illness, takes no medication. She is sexually active with one male partner. They use condom inconsistently. Her temperature is 37, pulse 110, blood pressure 90/50. Abdominal examination shows no abnormality. The uterus is consistent in size with the 16 weeks of gestation. No fetal heart tones are heard. Pelvic examination shows large amount of blood, large amount of dark blood in the vaginal vault with bleeding from the non-dilated cervix. Her hematocrit is 29%. Which of the following is the most likely diagnosis? Ready?
Mm-mm. Antideformal vaginal deliveries. Vaginal, and she has endometritis will be after the pregnancy. I'm between that they form more. Okay, I'm ready. Next. Ah, so the deform, I knew it. That the deformed moles are caused by either the fertilization of an empty egg by a single sperm, followed by duplication of the paternal DNA, resulting in 46 chromosomes complete, or dual fertilization of a normal ovum, resulting in 65 chromosomes incomplete. Maternal symptoms include first semester vaginal bleeding, abdominal pain, uterine size greater than expected, sorry, and hyperemesis gravidarum or persistent nausea vomited, the latter related to abnormally increased beta HCG concentrations. The vaginal bleeding may be significant and cause anemia with associated hypotension, tachycardia, hemorrhagic shock. Um, Additionally, increased concentration of beta HCG can stimulate the thyroid to secrete thyroid hormones, leading to symptoms of hyperthyroidism, such as, okay, I cannot read the rest, it went away. It's not vasa previa is associated with placenta previa, but refers to specifically to the condition in which blood vessels override the cervical O. While commonly diagnosed on routine screening, ultrasound symptoms of an unrecognized vasa previa include vaginal bleeding with rupture of membranes or sexual intercourse that can lead to fetal exsanguination. This patient is still early in the pregnancy and her membranes remain intact, making vasa previa unlikely.
Okay.
Okay.
Next.
So the symptoms on hyperthyroid formal will be, what
The
was that?
the symptoms of heredity for mole, there are like she is 12 weeks of gestation, but the product is more than 12 weeks of gestation, and there is no fetal heart sound. If there is product of conception, you may got the fetal heart sound, isn't it? But there is no fetal heart sound, and it is not abruptio placenta, because abruptio placenta happen. It can happen with the abdominal pain and bleeding, isn't it?
Yeah, I knew it wasn't a brush up placenta. It's too
Because
early.
it is within 20 weeks. Abruptio placenta is after 20 weeks of gestation.
So it's first semester vaginal bleeding, abdominal pain, and
Pain.
uterine
First,
size greater than
first
expected.
trimester bleeding, it can happen due to abortion. It can happen due to this
Mhm. Okay.
ectopy, identity formal.
Yes.
Okay.
Next.
A 32-year-old primary gravid woman, 15 weeks of gestation, persistent nausea and vomiting. Persistent nausea and vomiting for 7 weeks. She has 6-year history of infertility. The pregnancy is the result of ovulation induction therapy with clomiphene. The uterine fundus is at the umbilicus. Which of the following is the most likely diagnosis?
Mm,
Okay.
mm,
Is it multiple?
yeah, I guess. Okay. Let's see. Yeah, it's multiple gestations. Multiple gestation pregnancy occurs when more than one ovum is fertilized and implants in the endometrial lining of the uterus. While this can occur spontaneously, it is more common with reproductive technology such as ovulation induction, intrauterine insemination, and in vitro fertilization. Clomiphene use, as in this patient, simulates ovulation by blocking the negative feedback on GRH, gonadotropin releasing hormone in the hypothalamus, via acting as an estrogen receptor antagonist because it specifically stimulates ovulation more than when it can be produced and released during an ovulatory cycle, thus possibly leading to multiple gestation pregnancy. Multiple gestation pregnancy is most common diagnosed on routine prenatal ultrasound but may be suspected earlier because of hyperemesis gravidarum secondary to increased beta HCG concentration on a uteri larger than expected for current gestational age. Hmm. Complications of multiple gestation pregnancy include preterm labor, intra- intrauterine fetal growth restriction, twin transfusion syndrome, and fetal malpresentation. It's not highly titiform or commonly presents with persistent nausea and vomiting. First amidst the vaginal bleeding, preeclampsia, and uterine size out of proportion to the expected gestational age because, yeah, pelvic ultrasound will show diffuse echogenic structures. They didn't do a pelvic ultrasound. Okay. In the uterus and bilateral ovarian theca luteinsis. They are precursors to trophoblastic disease such as choriocarcinoma. Assistive reproductive technologies such as Comifed do not increase the risk of cardiac and is not incorrect dates. Incorrect dates may cause inaccuracies in expected uterine size and beta concentrations. Gestational age is typically determined by the patient's last menstrual period or by ultrasound early in the pregnancy. However, incorrect tests will not explain these patients' prolonged nausea and vomiting.
Okay,
Okay, next.
29. A 32-year-old woman gravid at 3 para to 40 weeks of gestation gives birth to 3.6 kg newborn by vaginal delivery. Upper score is 9 and 9 in 1 and 5 minutes respectively. Her pregnancy was complicated by low-lying anterior placenta. No evidence of placenta previa. Her two pregnancies ended in cesarean delivery due to low transaction due to low transversion. 50 minutes after the birth, the placenta has yet to deliver. Gentle firm traction is ineffective. There is no evidence of bleeding after 20 minutes. Continuous traction on the umbilical cord causes a firm fleshy mass appear through the introitus. In addition to arranging an anesthesia and placing an IV catheter, which of the following is the most appropriate next step? Ready?
Yeah. Is B. Immediate replacement of the uterus. Uterine inversion is a rare, life threatening complication of childbirth. Most commonly occurs during vaginal delivery when excessive traction is applied to the umbilical cord as the placenta is being delivered. Um, this results in inversion of the uterine fundus into the endometrial cavity, with severe cases presenting with uterine fundus at or beyond the introitus. Risk factors include microsomia, preeclampsia, uterine structural abnormalities, placenta accreta, the latter of which is likely present in this patient given her history of C-section deliveries and adherent placenta. Classically, uterine inversion presents with abdominal pain and severe vaginal bleeding. Physical exam will show absence of the fundus at the umbilicus, hmm, but rather it will be present on visual exam on the cervix and vagina. As the inverted uterus is unable to appropriately contract, uterine atony persists, and the patient is at risk for massive postpartum hemorrhage, leading to hemodynamic stability, hypovolemic shock. Treatment includes hemodynamic support and resuscitation, the administration of uterine relaxants, and immediate replacement of the uterus into its appropriate position. Delaying replacement can lead to edema and vascular congestion of the uterus, preventing further attempts at replacement. For this reason, initial attempts are unsuccessful. If initial attempts are unsuccessful, emergent laparotomy should be performed. It is not a immediate injection of ergo should be avoided. Ergo is a uterotonic that is used in the treatment of postpartum hemorrhage secondary to uterine atony. It increases smooth muscle contraction and muscular tone. which is beneficial in uterine atony, but will be detrimental in the management of uterine inversion because the uterus needs to remain relaxed in order to be replaced and prevent severe bleeding. Uterotonic should not be used. Okay. And it's not transvaginal hysterectomy may be required for this patient in order to remove the placenta. Okay. However, the more appropriate immediate step in the treatment of this patient is to replace the uterus into its appropriate position to minimize the risk of postpartum hemorrhage. Okay.
Okay. It 27-year-old primary gravid woman at 8 weeks of gestation comes to the physician for her first prenatal visit. She has no history of immunization and are up to date except MMR vaccine. She received a tetanus vaccine 2 weeks ago because she stepped onto a nail. She maintains a vegan diet and eats only organically grown food. In addition to prenatal vitamins, she takes calcium, zinc, vitamin A, vitamin B1, beeswax, rose. Each day she walks 3 miles for practicing yoga. Examination show no abnormal. Which of the following is the most appropriate recommendation for prenatal care?
Mm, mm,
Please,
it's one. I feel like it's one of the vitamins.
vitamin A isn't it teratogenic?
Is it?
Isotretinoin.
Yeah, right. It's probably that. Ready?
B1 thiamine is not teratogenic. Okay.
Okay. So it's vitamin A. Vitamin A is a fat-soluble vitamin found in a variety of food, such as greens, vegetable, carrots, um, egg yolks. It plays an important role in the maintenance of the cornea and conjunctiva, as well as phototransduction. As such, vitamin A deficiency can lead to night blindness and xerophthalmia. Alternatively, vitamin A toxicity can cause nausea, vomiting, and changes in vision when toxicity is acute, or ataxia, hepatotoxicity, and alopecia when toxicity is chronic. Okay. However, in pregnant patients, excessive ingestion of vitamin A can lead to teratogenic effects in the fetus. This includes microcephaly and cardiac effects, as well as spontaneous abortion. This patient is already receiving a sufficient daily dose of vitamin E with a prenatal and vegan diet and should thus decrease the other forms of ingested vitamin A, such as daily supplement to avoid fetal um, toxicity. It is not. I don't think I was confused about anything else. Oh, targeted ultrasound because of exposure to tetanus toxoid is not recommended. Tetanus toxoid is an inactivated vaccine that is safe to give during pregnancy and should be given without concern. Yeah. Okay. Next.
Okay. Can we take 2 minute break?
Yes, we
Okay,
can.
I'm coming.
Okay. Acute decreases in sodium concentration may lead to neurologic symptoms such as seizures, altered mental status due to cerebral edema. Chronic hyponatremia, in contrast, leads to less severe symptoms, such as nausea, vomiting, lightheadedness, fatigue, confusion. Causes of acute hyponatremia include administration of hypotonic fluid, SIADH, kidney dysfunction, adrenal insufficiency, beer potomania, psychogenic polydipsia, thiazide diuretics, This patient received significant amount of hypotonic solution, 5% dextrose in water, which likely decrease her sodium concentration. Additionally, large amounts of oxytocin can induce SIHDH, which which consequently cause water reabsorption. Patients who present with acute neurologic symptoms due to hyponatremia should be treated with um, hypertonic saline. It is not hypocalcemia commonly presents with numbness, secomo- secumoral numbness, paresthesia, and muscle cramps, although it may also be asymptomatic. In severe cases, seizures and prolonged QT interval can occur. However, hypercalcemia more commonly occurs because of hypoparathyroidism or kidney dysfunction, not administration of hypotonic fluids. Okay, next.
Yes. A 20, a 27-year-old woman, Gravita 1, Para 1, comes to the emergency department because of 1 day history of fever and malaise. She says that she's exhausted. She and has a decreased appetite. She is breastfeeding and has redness and discomfort of the right breast during this time. 4 weeks ago, she underwent forceps-assisted vaginal delivery. A healthy newborn who was recently treated for a thrush. She has no history of serious illness, takes no medication. Her temperature is 101 degree Fahrenheit. Pulse is 110 per minute. Respiration 16 per minute. Blood pressure 110 by 65. There is no lymphadenopathy. Examination shows erythema, induration, tenderness of the outer quadrant of the right breast. Both nipples are cracked and excoriated. The remainder of the examination showed no abnormality. Which of the following is the strongest predisposing factor for this patient's mastitis?
Ready?
Yes,
Okay, so the answer is nipple excoriation, mastitis, cellulitis of the um, breast tissue presents with unilateral red indurated edematous warm tender breast tissue and is frequently associated with fever. It classically occurs in breastfeeding patients, also termed lactational mastitis, as a result of nipple inoculation with cutaneous or oral flora. Nipple excoriation or fissures from breastfeeding are strong predisposing factor for mastitis as compromise of the skin barrier facilitates passage of organisms into the tissue. Secondary risk factors include incomplete breast emptying, relative immune compromise from maternal stress, malnutrition, lack of sleep, clogged duct, prior history, episode of mastitis, typhoid implant, and use of antifungal nipple creams. Staph aureus is most commonly causative agents. Others include coagulase negative staph, strep pyogenes, E. coli, lactational mastitis treated with oral antibiotics, and continuation of breastfeeding. Sequela of lactational mastitis include early cessation of breastfeeding due to pain and progression to breast abscess. Throughout history and physical exam are important to rule out inflammatory breast cancer, which can present similarly with unilateral breast edema, erythema, and pain, as well as characteristic pod orange appearance of skin. It is not B, C, or E. Incomplete breast emptying caused by infrequent feeding, milk oversupply, or clogged duct is a risk factor for lactational mastitis, as stagnant milk can provide a substrate for pathogens to grow. However, nipple excoriation facilitates inoculation of pathogen into the breast, which is the strongest risk factor. Newborn thrush has not been shown to increase the risk of lactational mastitis. However, maternal use of antifungal cream on the nipple does increase the risk of mastitis. Relative immune compromise caused by maternal illness, malnutrition, stress, or fatigue can impair healing of nipple trauma and impair immune response to pathogens introduced into the nipple. However, compromise of the skin barrier via nipple excoriation facilitates pathogen entry and is strongly stopped. Okay, next. Omar.
Yes,
Oh, okay.
3 hours ago, 3 hours ago, after admission to the hospital in labor, 32-year-old woman gravida 3 para 1 aborta 1 39 weeks of gestation. 39 weeks of gestation develops fetal bradycardia. The fetal heart rate decreases uh, from a baseline 150 to 60 per minute with no return to baseline after 8 minutes. The pregnancy has been uncomplicated. Amniotomy was performed after admission, and she has been receiving continuous epidural analgesia and pain control. Her first child was delivered by low transverse cesarean section. Her first child was delivered by low transverse cesarean section for breech presentation. Her pulse is 108, respiration 14 per minute. BP 100 by 60, cervix is 100% effaced, 9 centimeter dilated. The vertex is -3 station. Before the onset before the onset, which of the following is the most appropriate next step? Before the onset of the bradycardia, the vertex has been +1 station. Which of the following is the most appropriate next step?
Mm, ready?
Yes,
Oh, where is it? So it's laparotomy. Uterine rupture is a dangerous. Oh, is uterine rupture? Okay. It's a dangerous complication of pregnancy where the muscular wall of the uterus tears. Severe pain is a common initial finding. Hemodynamic instability can manifest in the mother with tachycardia and hypotension, and in the fetus with late decelerations, tachycardia, bradycardia, and loss of beat-to-beat variability. If uterine rupture occurs during labor, sudden loss of fetal station. Wait, he went from
he went from
+1 to -3, so he descended, right?
her
Or am I wrong?
cervix is 9 centimeter dilated, almost full dilatation, and
No, it
vertex.
is.
Oh, you are talking about the vertex -3
Yeah.
station.
I saw
Is
minus was that the thing is going down or no?
maybe I don't understand the plus and minus. That's why I can't comment on that.
Oh,
I
if
know
uterine,
you know about this. I don't know actually.
yeah, I think it's like
What is minus? Like
plus
what?
means
Yes,
it's minus station. I think minus means the baby has passed the. Let me see if there you go. This one. Why is it doing that? Okay, I don't know where I saw the picture, but I think it's this one. Why is it so small?
okay.
Oh, sorry. Plus means this is
Going this.
the
Okay.
yeah. Plus means going down, I guess.
So
Minus means
initially he starts going down, then she starts going up.
Yeah. Okay. Sorry, I got confused. Okay. So minus means yeah, it's above. Okay. Yeah, I got confused. Yeah, this one is better. It doesn't show. Never mind. Okay. So minus mean is going down and thing is going up. Okay. Where was I? Where is the thing? Right here. Wait, what is the is this one? Yeah. Okay. And the fetus deceleration loss of the if uterine rupture occurs during labor, sudden loss of fetal
Like how
station
we understand this is uterine rupture.
because
This,
it was at +1, so it was down, and then it went to -3, so it went up. So that means the uterus rupture and the baby start going back up.
okay,
Mhm. If uterine, blah, 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 so just fetal parts may be palpable above the fundus with Leopold maneuvers. These factors of uterine rupture include vaginal birth after C-section, multiparity, induction of labor with prostaglandin analogs like oxytocin. Uterine rupture is treated with emergent laparotomy. Okay, and it's not. Where was I? Forceps assisted. Forceps delivery is often used for a prolonged second stage of labor or in the setting of fetal distress. It requires a completely dilated and effaced vertex, rupture membranes, and an engaged fetal occiput. This patient is not completely dilated and has had sudden loss of fetal station. Laparotomy is the most appropriate next step. Okay. Okay.
okay. Can you hear me?
Yeah.
Okay. A 32-year-old man, gravida 3 para to 34 week, gravida 3 para to 34 weeks of gestation, comes to the emergency department 2 hours after the sudden onset. 2 hours after the sudden onset vaginal bleeding, her pregnancy had been uncomplicated. Examination show uterus consistent with the size of 34 weeks of gestation with normal tone. The fetal heart rate is normal, contraction is irregular. Over the next hour, she has increasingly severe pain with contraction. Her pulse is 82 per minute, respiration 14 per minute, blood pressure 170 by 110. The fetal heart rate is 150 to 160 per minute, deep tendon reflexes 4 plus. Which of the for a lab study hemoglobin 10.1, leukocyte count is high, low platelet. AST is 120 high, LDH high, urine protein is high. Which of the following is the most likely cause of this patient's vaginal?
Mm, I don't know what's body show.
Isn't it preeclampsia?
I don't know.
BP
But,
140 over 90 after 20 weeks of gestation with proteinuria, and
but that's not an option here.
but
Um,
the cause of the preeclampsia.
so you think it's abrupted placenta? Um, the fetal heart pattern is normal. She doesn't have any uterine severe pain with contractions. Yeah, maybe. Lactic dehydrogenase. It's high. I don't know. Ready?
Yes.
I know it's between abruptio and DIC, I guess. It is abruptio. Um, oh, I cannot even read the thing. Abortion placenta or placental abortion refers to premature separation of the placenta from the uterus. Most commonly presents with vaginal bleeding, severe preeclampsia, lab abnormalities, also include proteinuria, thrombocytopenia, and increased liver enzyme. In addition to vaginal bleeding on physical exam, patients with placental abortion will show uterine tenderness to palpation and abdominal rigidity. Because of the compromised fetal blood supply, it is an obstetric emergency. Treatment includes supportive care through resuscitation, emergency C-section, Rh immunoglobulin, if the maternal blood type is Rh negative. It is not DIC, may present with vaginal bleeding, in addition to diffuse bleeding from other sites, mouth, gums, IV sites. Lab studies would show thrombocytopenia, prolonged PT and PTT, increased dimer concentration, decreased fibrinogen. In pregnant people, it is more commonly related to blood loss associated with placental. It is most commonly related to blood loss associated with placental abortion or postpartum hemorrhage, amniotic fluid embolism, and sepsis. This patient has no other signs of bleeding and no coagulation studies to determine whether DIC is present, making placental abortion the most likely immediate cause of her vaginal bleeding. Okay, okay.
Next, a, a previously healthy 27-year a previously healthy 27-year-old woman, gravida 2 para 2, comes to the physician because of 1 week history of tender mass at the entrance of the vagina. During this time, she has had discomfort in this area during sexual intercourse. She is sexually active, one male partner. They use condom inconsistently. Pelvic examination show 4 centimeter fluctuant, moderately tender mass located at 7 o'clock position related to opening of the vagina. Which of the following is the most likely cause of this patient's finding?
Mm, don't know. Ready?
Yes,
Okay. So it is bacterial infection. Shit. Bartholin abscess can occur when the Bartholin gland becomes obstructed and infected. Bartholin gland is located on each side of the introitus at the 5 o'clock. What is 5 o'clock? 3, 4, 5, and 7 o'clock. Okay. Positions relative to the opening of the vagina. These glands produce secretions that lubricate the vagina. Occasionally, the ducts of these glands become obstructed, leading to patholysis. This presents as a small area of painful fluctuant swelling over the posterior aspect of the major. Um, labium major, okay. With ongoing obstruction and inflammation, infection can develop, leading to Bartholin abscess, marked by redness and tenderness to palpation of the cyst. Okay. Abscess are commonly polymicrobial bacterial infection with organisms originating from both the skin and the enteric flora. If a single organism is identified, it's usually Neisseria, but it's not as common as polymicrobial source. Bacterial abscesses are treated with incision and drainage, often with the placement of a catheter to promote complete evacuation, and generally also with antibiotic administration. Okay, so it goes is the cyst first and then it goes without. It- it's not viral infection can cause abnormalities of the vulva. For example, infection with herpes can cause small Painful vesicular lesions. Viral infection are not causative of Bartholin abscesses. Okay, got it.
Next,
Mhm.
a 22-year-old woman comes to the emergency department because of 12-hour history of severe right lower quadrant abdominal pain. Her last menstrual period was her last menstrual period 8 weeks ago means had previously occurred at regular 28 days of interval. Abdominal examination shows right lower quadrant tenderness. The uterus is constant in size at 8 weeks of gestation. There is no right adnexal tenderness. Her qualitative serum beta HCG is 10,000. Transvaginal ultrasound show a gestational sac in the uterus containing a yolk sac. There is 3 cm complex right adnexal mass. Which of the following is the most likely diagnosis?
Kind of lost on this one. She has a normal pregnancy, but the right lower quadrant mass, and it's a complex mass, but it's tender. Okay, ready? And
Yes.
she's 22. So it's corpus luteum cyst. The corpus luteum develops from mature follicle after the egg has ovulated during the menstrual cycle. During pregnancy, it enlarges and secretes progesterone to maintain early pregnancy until the placenta begins to synthesize. This enlarged corpus luteum can form a cyst, which can potentially rupture. Ruptured corpus luteum cyst classically presents with unilateral pelvic and lower abdominal pain that is sudden in onset and severe. Okay, most commonly after sexual intercourse or other physical activity. Physical exam may show unilateral adnexal mass, which may be tender. However, if the cyst has completely collapsed, it will not be evident on physical exam. Pelvic ultrasound will show a complex cystic mass, complex, of free fluid in the pelvis if rupture has occurred. May include hemorrhagic components. Choledocentesis do rarely perform TK to produce serosanguinous fluid as the corpus luteum is highly vascular. These cysts are typically managed with observation and supportive therapy. Mm, Okay, and it's not what was that? Was between endometrioma CD. Now, see, endometrioma is a cyst that is formed from endometrial tissue within the adnexal. In a patient with endometriosis, if palpable on physical exam is often adherent to nearby structures. Endometriosis commonly presents with dysmenorrhea, dyspareunia, dyschezia. This patient had no previous symptoms of endometriosis. Endometriomas do not present with acute pain, making it unlikely. Hydatidiform commonly presents with persistent nausea and vomiting. First trimester vaginal bleeding, early preeclampsia, and uterine size out of proportion to the expected gestational age. Beta HCG will be increased, as in this patient, ultrasound will typically show diffuse echogenic structures in the uterus and bilateral ovarian thecal lutein. Okay, next.
A 42-year-old a 42-year-old woman comes to the office because of 1 year history of progressively irregular, increasingly painful menstrual period. During this time, she also has had pain during sexual intercourse. Mens occur at 18 to 23 day interval, last 10 days. Mens previously occurred 28 days interval. The patient has no history of serious illness, takes no medication. She is sexually active, monogamous with her husband who has vasectomy 10 years ago. The patient is 5 feet 6 inch tall, weight is 150 pound, BMI 24 kg per meter square, temperature 98, physical examination, uterine tenderness to palpation. The remainder of the examination shows no abnormality. An endometrial biopsy specimen obtained 28 days after the last menstrual period with the secretory endometrium of the plasma cell. Which of the following is the most likely diagnosis?
Right. I'm so lost. Endometrial hyperplasia. Social secretory endometrium plasma cells. Irregular menstrual period. This time she also has painful sexual intercourse. Patient. I don't know. Ready?
Yes.
Okay. So it is chronic endometritis. Did not see that one coming. Endometritis refers to inflammation or infection of the uterine lining. It may be acute or chronic, with acute endometritis most commonly being caused by PID. PID is characterized by inflammation of the upper genital tract and pelvis and presents with fever, abdominal pain, mucopurulent discharge, as well as cervical motion and uterine tenderness on exam. Ascending chlamydia and Neisseria infections are common uh, bugs involved in the development of PID. Okay, chronic endometritis, in contrast, is most commonly idiopathic or inflammatory. Less common causes of Less common causes include pelvic radiation therapy, infection, IUDs, fibroids, polyps. Presenting symptoms include abnormal uterine bleeding and abdominal pain, with physical exam disclosing uterine and cervical motion tenderness. Although physical exam may also be unremarkable. Okay, abnormal uterine bleeding refers to bleeding that is irregular, unpredictable, and not associated with menstruation symptoms. If an endometrial biopsy is done for evaluation of abnormal uterine bleeding in chronic endometritis, it will show plasma cells in endometrium. Okay, that's the key. As in this patient, treatment of chronic endometritis is dependent on the line cause, but may include antibiotic therapy, removal of the foreign body, or surgical excision of intrauterine growth. It is not, what did I pick? The hypergonadotropic or primary hypergonadism often refers to premature ovarian follicle failure. Premature ovarian failure presents with in reproductive age women with an ovulation, amenorrhea, infertility. Lab studies show decreased estrogen with increased FSH. It more commonly occurs in patients younger than 40 and will be unlikely to cause abdominal pain. Okay.
Okay, next. 30 minutes after undergoing forceps assisted 30 minutes after undergoing forceps assisted vaginal delivery. A healthy newborn at term hospitalized a 19-year-old woman gravida 1 para 1 reports a 15-minute history of increasingly severe vulvar pain. The infant weight is 3.3 kg. Pregnancy was uncomplicated. She received a routine prenatal care. She has a history of serious illness, and her only medication is prenatal vitamin. Pelvic examination show 5 centimeter fluctuant tender discolored mass of the left labial majors. Examination is consistent with vulvar hematoma. There is no vaginal hematoma or edema laceration of the following artery. Which of the following is the most current condition?
That's vulva. I don't know. Ready?
Yes,
Okay. It is pudendal. That was a good guess. Pregnant patients are at risk for development of puerperal hematomas during delivery. These hematomas may occur in the vulva, vagina, retroperitoneum. Risk factors include nulliparity, macrosomia, operative vaginal deliveries, and extended second stage of labor, bleeding, diastasis, preeclampsia. Vulvar hematomas are most commonly caused by injuries to the pudendal artery. In contrast, vaginal retroperitoneal hematomas are caused by injuries to the uterine and hypogastric arteries. So, uterine artery for vaginal hematoma and hypogastric artery for retroperitoneal hematoma. Presentations also vary, with vulvar hematoma presenting with fluctuant and painful discolored masses in this patient, vaginal hematomas causing rectal pressure, and retroperitoneal hematomas exhibiting hemodynamic instability. Treatment of vulvar and vaginal hematoma is often supported with ice pack and analgesia, but may require incision and drainage. Retroperitoneal hematoma requires surgical intervention.
I don't
It is
understand this. Like they said, uh, we can you just elaborate?
there is nothing to elaborate. You just have to. It's just a memorization question.
Like why not uterine artery?
Okay, uterine artery is a branch of the internal iliac artery that supplies blood to the uterus. Uterine artery injuries may be caused by operative vaginal delivery. These injuries more commonly lead to vaginal rather than vulvar hematomas.
So vulvar hematoma is specific for pudendal artery, pudendal artery.
Yes, vulvar hematoma for pudendal, vulvar hematoma pudendal artery, uterine hematoma for, sorry, vaginal hematoma for uterine artery, and vaginal artery, let me see, vaginal artery supplies blood flow to the vagina. In woman, it arises from internal iliac artery anastomosis. With, yeah, vaginal artery injury may cause vaginal hematoma, but would like, okay. So for vulvar hematoma, you have pudendal artery. For vaginal hematoma, you have uterine artery and vaginal artery. And for retroperitoneal hematoma, you have hypogastric artery. This is just, you just have to memorize, there is no
Okay.
way. Yeah. Okay. Next.
A 20-year-old woman comes to the office because she has been amneric for 6 months. She has an increasing time interval between mens over the past 2 years. She has no history of serious illness. She uses a diaphragm for contraception. She is 165 centimeter, weight 49 kg, BMI 18 kg per meter square. Her blood pressure is 100 by 60. Examination show no normal finding. Urine beta hCG is negative. Which of the following is the most likely cause of her amenorrhea?
Alrighty.
Okay.
Okay. So it is irregular secretion of gonadotropin. Secondary amenorrhea may be caused by pregnancy, menopause, premature ovarian failure, ovulatory dysfunction, abnormalities of the HPO axis, inadequate nutrition, chromosomal abnormalities, thyroid disorder. Functional hypothalamic amenorrhea refers to amenorrhea that occurs in the setting of increased stress or decreased energy availability, which may be secondary to inadequate nutrition or overexercising. Um, Often in a patient with low BMI. In order to diagnose functional hypothalamic amenorrhea, pregnancy and other pathology should first be excluded. It's caused by a decrease in GnRH, which consequently causes irregular secretion of FSH, ovulation, and estrogen production. Hypercortisolemia caused by stress may also play a role in the inhibition um, of GnRH. It is not D, as in dog. Increase in serum TSH hormone concentration is seen in primary hypothyroidism, which most frequently present with fatigue, weight gain, constipation, cold intolerance, oligomenorrhea. It may also cause infertility due to anovulation. This patient has no other signs of hypothyroidism, such as weight gain. Okay, got it. Next.
A 72-year-old woman comes to the physician because of 2-month history of progressive nausea and vomiting and increasing abdominal GERD. Bowel sound are hyperactive and high-pitched rashes. There is no shifting dullness. Bimanual examination shows a right-sided pelvic mass. Which of the following is the most likely cause?
Ready?
Yes.
Let me see. Is ovarian cancer. Ovarian cancer commonly presents with indolently with abdominal distension, early satiety, weight loss, in postmenopausal woman. Signs and symptoms of advanced disease may also include bowel obstruction with consequent nausea and vomiting, ascites, pleural effusion, and venous thromboembolism. In addition to this, physical exam may show palpable hardness of mass on bimanual exam or lymphadenopathy. Ultrasound is recommended to identify or characterize the responsible lesion with concerning features including septation, cystic components, blood flow, and heterogeneous structures. Further evaluation is completed with tumor markers, commonly CA125. An additional imaging to determine the extent of the disease. These factors of the development of ovarian cancer include the family history, BRCA mutation, increased age, molecular parity, pelvic radiation. Treatment is surgical removal of the uh, removal, surgical removal and chemo. Sorry. Can we take a break?
Yes.
Okay, take a quick break.
Okay.